So good morning once again. We'll be talking about deep fluid volume regulation this morning. So hopefully at the end of our session today, we will be able to meet the following learning objectives for this unit. One is that hopefully we'll be able to identify the compartments of the fluid in the body and what are the respective volume in a typical 70 kilogram individual. And then, of course, explain the importance of sodium in the way it is able to control fluid volume in the body. Also, state where in the nephron most sodium and water are reabsorbed, and state what are the mechanisms by which this happens. Then, hopefully describe in detail what we call the RAAS system, the renin, angiotensin, aldosterone system, and the actions, particularly of angiotensin 2 with regards to fluid volume regulation. Explain the responses, renal responses to specific conditions that are pathologic in nature, particularly cardiac failure, liver failure, and even hypertension. So paano ba nag-respond yung renal system to these conditions in the body? And then list causes of hypertension and what are the basic management steps with regards to hypertension. And then also understand the differences between the different types of diuretics and state which are considered the most powerful diuretic, because this is the most common approach to the management of hypertension today, the use of diuretics. And then, of course, we'll try to take a look at the side effects of this commonly used diuretics, particularly your thiazide diuretics. And what are the mechanism of actions of your potassium-sparing diuretics? And finally, understand the effects of your ACE inhibitors, because ACE inhibitors are one of the more common medication that is given in the clinics to deal with hypertension. And we will try to take a look at what will happen if you face a patient that has a condition called renal artery stenosis, and we can take a look at that. So hopefully all of you are able to finish the quiz already. So take a look at the answers later during the session. So let's now go to the control of your body fluid, and what are the basic concepts that are used. So this is just a review, since in the video of the last learning unit, you already introduced to the kidney and the urinary system in general and how it controls homeostasis in the body. But just as a reminder, when you talk about body fluid, pag pinag-uusapan natin yung fluid sa katawan ng tao, they are generally divided into two. The extracellular fluid and your intracellular fluid. So your intracellular fluid, or ICF, are the fluids found within the cells. So yung within the cells, meron tayong fluid that we call ICF. And outside of the cell, you have your extracellular fluid, or your ECF. Further, your ECF is divided into three. You have your plasma, you have your interstitial fluid, and your transcellular fluid. Yung plasma natin, usually, this is found within the vascular system, so within the vessels, blood vessels of the body. So these are the non-cellular component of blood. So doon sa dugo natin, the non-cellular components are categorized as plasma. Yung interstitial fluid, on the other hand, is the part of the ECF that are outside the vascular system. So yung ECF na nasa labas ng blood vessels ng katawan and are separated also from the plasma by your capillary endothelium are called your interstitial fluid. So if you have discussed your lymphatics you will know that your interstitial fluid plays a big role, no, in the lymphatic system. And you also have your transcellular fluid or your TCF. Hindi ito masyadong common na nadi-discuss sa body fluids, but they exist, no? So your ECF, for example, your synovial fluid, your aqueous and vitreous humor within your, of course, your eyeball, your cerebrospinal fluid, of course, within your spine, your CSF, of course, also within your nervous system, are separated from the plasma by capillary endothelium and an additional epithelial layer that has a specialized function. So this is a figure that shows to you the different location, no, of these components of your body fluid. You have your ICF or your intracellular fluid found within the cells of the tissue. Then you have your transcellular fluid, TCF, which is a small percentage of your body weight found, for example, within your synovial fluid or your CSF. And inside the blood vessels of the body, you find your plasma, which is about 5% of the body weight, no? And finally, in between the cells of the body, you have your interstitial fluid. So outside of the cell, you have this interstitial fluid. This is about 15% of the body. So around 20% of your body weight, or about 15 liters in terms of volume, can be considered as part of your ECF. While your ICF comprises the remaining part of your body. So for your ICF, it's about 40% of body weight, or about 30 liters of volume. So water is a major component of your human body, no? And approximately 60 to 50%, no, of your 50 to 60% of your water, of your body weight, is comprised of water. So may pagkakaiba lang ng konti between males and females. Of course, there is more water in males. In some textbook, there are about 63% of the body in males is water, while in females, it is a little bit lower at around 52%, no, is water. This is because females have a higher proportion of body fat. So in terms lang ng composition of the body, females tend to have more body fat. So this is due to hormonal differences. So because fat has a lower content of water, as a result of these differences in terms of body fat proportion, where females have more fat, which has less water. Therefore, females will have less water in the body compared to your males. So in general, the rule of thumb is that 1/3 of the total body water is extracellular fluid. So it's about 15 liters in a typical 70 kilogram male, and 2/3 is ICF, no, your intracellular fluid, comprised of the different components, no, of your ICF, as I mentioned earlier. And this is about 30 liters in a 70 kilogram male. So the volume of fluid that are perfusing the tissue, no, that are providing nourishment to the tissue, is your effective circulating volume. And because this has something to do with the metabolic requirements of the body, therefore this effective circulating volume needs to be kept constant. Kasi nga kailangan ng marami kasing metabolic processes in the body that needs a stable environment, or the values of the body processes should be kept at a narrow range, no? For example, in terms of volume, in terms of concentration of solutes, in terms of electrolytes, and water composition. So this needs to be kept constant. And pag-uusapan natin yan in a few minutes. Now, another important concept with regards to body fluid regulation is the sodium balance. Why is it important to take at sodium balance? Sodium, of course, generally associated with salt, no? Sodium is the major cation or the major positive ion in the ECF. And the normal concentration of your sodium in the body is about 135 to 145 millimoles per liter. So that is the normal range for sodium in the body. Therefore, given this concentration of sodium in the ECF, it actually controls 90% of the osmolality of the body fluid. No? So 90% of your body fluid osmolality is taken from sodium. And as we have learned in the previous week, osmolality of the plasma is carefully controlled by the loop of Henle. So if you remember your tubules, no? The plasma osmolality or the concentration of solutes is controlled by the loop of Henle and of course by the collecting duct. So in terms of reabsorption or absorption, secretion of water and of course other electrolytes. So therefore changes in the amount of sodium in the ECF will actually lead to changes in the extracellular fluid volume. So pag nagbabago yung sodium level sa ating body fluids, no, it will also lead to changes in the volume of your body fluid, particularly your ECF. So for example, a rise in your ECF sodium will result in increased osmolality. So pag masyadong mas maraming sodium doon sa fluid, this will raise osmolality. And the net effect of this, because this is more concentrated, will lead to water retention. And this will generate the feeling of thirst, no? And because our osmoregulators, no, in the nervous system will detect this, and this will lead to the behavior of increased water intake, no? So you will increase your intake of water as a result of increased sodium concentration in the fluid, particularly in the ECF. So this increase in ECF volume, this leads to increase in ECF volume because of the water intake and normalizes osmolality also. So what is important to note is that the kidney therefore regulates the amount of sodium that the body absorbs, no? So alongside the mechanism regulating osmolality, for example, the thirst mechanism, no? The neural mechanism, the behavioral mechanism that is triggered by changes in sodium concentration in the body fluid. Together with the kidney, they control your extracellular fluid volume. All right. So let's now go to how sodium actually is handled by, excuse me, by the kidney. So your sodium is regulated by your kidney, and the concentration of sodium in the Bowman's capsule. So if you remember your Bowman's capsule, this is a specialized structure in your kidney that is coming from your afferent arterioles, no? And the concentration of sodium in the Bowman's capsule is equal to the plasma level, no? To the level found in the blood. Because sodium is freely filtered in the capsule. So virtually all of the sodium is filtered into the nephron is reabsorbed back into the circulation with only about 1%, no, of the with only about 1% of your or less, no, of the sodium being excreted in the urine. So 99% of the filtered sodium in the Bowman's capsule is actually filtered back. Uh, uh, so only 1% is excreted in the urine, no, because of this function of reabsorption into the circulation. So let's take a look at how sodium is transported in the proximal tubule. So there are several segments. You have your proximal tubule, then you have your distal tubule, and of course you have your loop of Henle, where there is active metabolic processes that transport sodium. So let's first take a look at your proximal tubule. A lot of sodium is reabsorbed in the early proximal tubule, but as the cell junctions are leaky, so remember the cell junctions are not really tight, no? So the gap between your proximal tubule cells are not really bridged very tightly. So the concentration gradient between the filtrate and the intercellular plasma is limited. So walang masyadong difference between the different compartments because of the leaky cell junctions. There is less reabsorption that occurs in the late proximal tubule, but the cell junctions are tighter. So in the late proximal tubule, the cell junctions are tighter, so a better concentration gradient is established and in the more distal parts of your proximal tubule. The primary transporter, your sodium, potassium ATPs, no? Your sodium pump, your sodium potassium ATPs, or your sodium pump on the basolateral membrane actively transports sodium out of the cell into the lateral intercellular spaces between adjacent cells. So your sodium ATP, sodium potassium ATPs pump is an active transporter of your sodium out of the cell into the lateral intercellular spaces. So this movement of your sodium out of the cell maintains a very low concentration of sodium within the proximal tubule cell. So this drives your sodium ion to move along their concentration gradients into the cell from the tubular fluid via carrier molecules. So there are carrier molecules that through passive diffusion are being driven along by your concentration gradient. So this drives sodium ion to move along their concentration gradients into the cell from the tubular fluid via carrier molecules into the apical membrane. So in the early part of your proximal tubule, movement of other substances, for example, your glucose or your amino acids and your phosphate is coupled with your sodium transport in and out of tubule cells. And the fluid leaving the proximal tubule is isosmotic because both ions and water move out of the filter together. In other words, your proximal tubule has no concentrating capacity, no, in terms of the ions that passes through that part of the tubule. On the other hand, your distal tubule also handles, together with your loop of Henle, also handles sodium. Now, the complicated mechanism, let's take a look at, okay, so this is a table showing to you the different parts of the nephron. So you have your proximal tubule, your loop of Henle, your early distal tubule, and your late distal tubule, and the amount of sodium that are filtered and then subsequently reabsorbed. No? And also you will see here what are the transport mechanisms for the entry of sodium into the cell. No? And of course, what are the hormones that regulates this activity along that particular part of the nephron? So for example, for your proximal tubule, you have your sodium, your sodium co-transport, which transport sodium along your paracellular route using, of course, your sodium gradient, no? Your sodium concentration gradient between the cell and the intercellular spaces. Then the regulator hormone here for this co-transport is your angiotensin II. For the loop of Henle, you have your sodium chloride potassium pump, and the regulatory hormone here is your aldosterone. And your early distal tubule, you have your sodium chloride symport, and your hormone here is aldosterone also. And of course, you have your sodium channel in the late distal tubule and your collecting duct, which are used to concentrate urine. And your regulatory hormone here is your aldosterone and your atrial natriuretic peptide. So most of the segments of the nephron is actually under the control of your aldosterone, and that's why it's a powerful hormone in terms of controlling fluid volume, or regulating fluid volume. So let's now take a look at the distal tubule and how it handles, together with the loop of Henle, the sodium. So the complicated mechanism by which the loop of Henle handles sodium is mainly to create a concentration gradient to allow for the controlled osmolality. So what it does is actually just create a huge difference in concentration between the different compartments, no, along the tubule to drive passage of different electrolytes. So the distal convoluted tubule reabsorbs only about 10% of filtered sodium, but this amount is adjustable and is important in the control of your body fluid volume. Also, your sodium leaves the basolateral side through the sodium potassium ATPase and enter the cell from the lumen through a sodium chloride co-transporter. So you call that your sodium chloride symport, due to the concentration gradient established by the active pumping of your sodium out of the cell into the intercellular interstitial spaces. Now let's take a look at your renin-angiotensin-aldosterone system. Your renin-angiotensin-aldosterone system is one of the important homeostatic mechanism that maintains constant fluid volume and also, in a way, controls your blood pressure in the body. So in this figure here, you will see an illustration of your renin-angiotensin-aldosterone system to maintain sodium balance. So there are several components to your renin-angiotensin-aldosterone system. So this involves the kidney, also involves the liver, and it also involves certain portions of the tubule, no? And later on, we will also know that even the lungs are involved, no, in this renin-angiotensin-aldosterone system. And of course, the final effector hormone of your renin-angiotensin-aldosterone system is your aldosterone, because the aldosterone, as we have seen in the previous table, controls a lot of the segments in the nephron that has something to do with sodium reabsorption and water fluid volume reabsorption. So let's take a look at the specific components of this renin-angiotensin-aldosterone system. So your renin is actually an enzyme that is synthesized and stored in the kidney, particularly your juxtaglomerular apparatus, your GGA, no? As you have seen in your previous learning unit last week, where you were introduced to the GGA, no? The juxtaglomerular apparatus in the kidney. And that is where your renin is actually synthesized and stored. So whenever your plasma sodium decreases, this leads to a fall in the ECF volume, and this decrease in ECF volume is detected by the kidney, and this caused the release of renin. And the mechanism by which this happens is that when there is a fall in sodium concentration, which leads to decreased ECF volume, because less salt means less water, di ba? Kasi water just follows where the salt is. So if there's less salt in the ECF, therefore there will be less salt in the there will be less water in the ECF. And therefore, this will lead to an increased sympathetic innervation. So these events, decreased plasma sodium, decreased ECF, will lead to sympathetic activation. So increased sympathetic activation due to the fall in ECF volume, which leads to a fall in blood pressure. And this fall in blood pressure is detected by your baroreceptors in your carotid arteries. So the baroreceptors in the carotid arteries, because of the decrease in the blood pressure, because of the decrease in the ECF volume, because of the decrease in sodium, so you see the relationship there, will be activated. And the activation of your baroreceptors will lead to increased sympathetic activity. So magkakaroon ng sympathetic stimulation. And then now your granular cells in the juxtaglomerular apparatus, or your GGA, which are of course innervated by your sympathetic system, will be activated as a result. And this will lead to an increase in the sympathetic activity of the body, which leads to an increase in renin release. So there is an increase in renin release. And of course, this process is mediated by your beta adrenergic receptors, because this is part of your sympathetic nervous system. So the wall tension also, for example, in decreased ECF. So nagkakaroon ka ng decreased water volume. So therefore, there will be decreased ECF volume. And therefore, because of the lesser volume in the blood vessels, will lead to hypotension, di ba? Siyempre, bababa yung blood pressure. Therefore, the decrease in the tension in the walls of the afferent arteriole will lead to decreased perfusion pressure in the kidneys. Kasi konti na lang yung pumapasok na pressure doon sa kidney because of the decrease in the ECF volume in the body. So therefore, these changes in the blood pressure will decrease wall tension and the granular cells. And ito, nadidetect din ito ng granular cells, decrease. So aside from the sympathetic innervation that is activated, there's also the detection of the decrease in blood pressure in the wall of the granular cells, and this will also lead to renin release. No? So this is another mechanism for renin to be released from the granular cells. So that's the second one. The third one, the third mechanism for the release of renin is because of the decrease in sodium in the ECF volume. And this decreased sodium in the ECF is detected by your macula densa. So remember, you also have your macula densa in the kidney that detects sodium concentration in the blood. And if there is less sodium in the blood, this is detected by your macula densa. And therefore, the macula densa is stimulated to secrete your prostaglandin, no? Prostaglandin. And this acts on the granular cells to cause renin release. So increased prostaglandin release, PGI2, from your macula densa will also stimulate the granular cells to release renin. And as a result, renin is released. And what's the effect of renin? The effect of renin is basically to convert your angiotensinogen that is secreted by the liver, or you call this your alpha-2 globulin, no? Your angiotensinogen or alpha-2 globulin is acted upon by your renin by splitting off angiotensin 1, no? So it cleaves no, angiotensin 1 from your angiotensinogen, which is a more active enzyme from your angiotensinogen. No? Angiotensin 1 is more active. Now, on the other hand, hindi doon natatapos, no? Because your angiotensin converting enzyme in the lungs, no? Your angiotensin converting enzyme found in the lungs, then converts your angiotensin 1 to the more active angiotensin 2, which is an octapeptide, no? Angiotensin 2, which is a more active enzyme, hormone that then acts to stimulate the production of aldosterone by your adrenal cortex. So that is the effect of your angiotensin 2. It stimulates the zona glomerulosa of the adrenal cortex to release your aldosterone. Aside from its stimulatory effect on the adrenal cortex to release aldosterone, your angiotensin 2 has other effects also. So remember, it has also other effects. And what are the other effects? It also directly vasoconstrict blood vessels, particularly within the kidney. No? So your angiotensin 2 will directly vasoconstrict your arterioles within the kidney. And the effect of vasoconstriction is more pronounced, no? More pronounced in your efferent arteriole. So yung mas nakoconstrict ay yung efferent arteriole versus your afferent. So anong net effect nito? So ibig sabihin yung inflow arteriole, which is your afferent, versus your outflow arteriole, which is your efferent, ay magkaiba yung kanilang response to aldosterone. Magkaibang response na to angiotensin 2. Ang efferent arteriole is mas mataas yung level of vasoconstriction. And so what's the effect here? So if you have more inflow and less outflow because of the more greater vasoconstriction, no, of your efferent arteriole, so therefore lesser yung outflow compared to inflow, mas nare-raise yung blood pressure ngayon within the renal tissue. So that is one of the effects of your angiotensin 2. So it actually increases perfusion, no, of your renal tissue. On the other hand, also your angiotensin 2 directly increases sodium reabsorption from your proximal tubule. So your angiotensin 2 increase reabsorption, and because of the increased reabsorption, it therefore will lead to less sodium elimination. And therefore, what is the net effect? The net effect is salt is retained in the body. So sodium is retained in the body, and as a result, it will retain water. No? Hindi siya nag-excrete ng water. So there is increased water retention. Also, there is increased potassium excretion. Also, your angiotensin 2 has other activities. No? It also releases antidiuretic hormone, which also acts on the distal convoluted on the distal portions of your tubule. It also stimulates the thirst mechanism of the body, and also provides negative feedback to your juxtaglomerular apparatus cells, your JJ cells, and therefore affects renin release. So this is also has a feedback loop that somehow moderates the release of renin from your GGE cells. Kasi kung masyado nang marami yung angiotensin 2, so hindi na kailangan, no, ng mag-release ng renin, because renin is the one that activates your angiotensinogen to become angiotensin 1. No? And that becomes a substrate now for the creation of your angiotensin 2. No? And it is a form of, it provides a negative feedback mechanism also to your JGSS para hindi naman karoon ng sobra-sobra namang increase ng renin. So in addition to the generation of your circulating angiotensin 2, the local generation of angiotensin 2 by your ACE, your angiotensin converting enzyme, your ACE, within the tissues might have an important pathogenic role. So yung pag-increase naman ng ACE, no, angiotensin converting enzyme, because of the activity of your RAS can also lead to pathology. So, for example, pwede mag-generate ng hypertension. So that is why ACE inhibitors are also used to treat high blood pressure, because what they do is they inhibit your angiotensin converting enzyme from acting on your angiotensin 1 to become angiotensin 2, which is the more active metabolite that leads to water and sodium retention. Also, your ACE inhibitors, they decrease the production of angiotensin 2, and consequently, they will decrease vasoconstriction. So, decrease in vasoconstriction, and they also decrease aldosterone, and therefore prevent an increase in your ECF volume. Now, tingnan naman natin yung aldosterone. Ano ba yung function ng aldosterone? Aldosterone is synthesized by your zona glomerulosa cells in the adrenal cortex. So once your adrenal cortex is stimulated, it releases your aldosterone or release your aldosterone. Now, ano ba yung mga nakaka-apekto sa release ng aldosterone? So unang-una, it is affected by your angiotensin 2. So if you have an increase in angiotensin 2, it will increase aldosterone release. Pangalawa is your decrease in ECF volume. So nakita natin naman in ECF volume, if your sodium levels decreases, the effective circulating volume also decreases. And therefore, this stimulates the release of aldosterone via the renin-angiotensin aldosterone system. So therefore, ECF volume is a big part in the stimulation of the release of your aldosterone. Also, your plasma sodium concentration is affecting your aldosterone release via direct aldosterone release from the adrenal cortex, as well as through the renin-angiotensin aldosterone system. And finally, also remember your plasma potassium concentration also affects your aldosterone release. An increase in potassium in the circulation will stimulate directly the release of aldosterone from the adrenal cortex. So potassium is a direct stimulant for the release of aldosterone from the adrenal cortex. Because the aldosterone actually is important in the regulation of plasma, because if you look at this on figure here, you know that your aldosterone acts by increasing potassium excretion. So pag tumataas yung potassium mo, so for example, meron kang hyperkalemia, one of the ways by which the body eliminates potassium is by eliminating it through the kidney via the action of your aldosterone. So aldosterone, therefore, primarily regulates sodium concentration. However, it can also regulate potassium concentration. So aldosterone acts within the cell by promoting sodium reabsorption in the kidney, in the colon, even in the stomach through the gastric glands, and even in the sweat and salivary gland duct. So aldosterone acts in different parts of the body to reabsorb sodium. It reabsorbs sodium. And another function of your aldosterone is retention or increase in excretion of the hydrogen and potassium ion through the kidney. So the net effect of these actions, for example, is to increase ECF volume and increase plasma sodium, and also to increase excretion of potassium hydrogen ion, and also decrease in the level of plasma concentration of potassium. So it is important to note, what is the clinical correlation here? It is important to note, for example, in conditions where you have your problems of your adrenal glands. One of the conditions you might meet in the clinic is what is called adrenal insufficiency. Adrenal insufficiency is a condition where the adrenal glands fails to secrete the required hormone levels. So hindi nakakapag-secrete ng hormone. Kasama na dyan, of course, yung aldosterone. So it normally has a non-specific presentation uh, unless the patient is having an acute adrenal crisis, which is typically life-threatening. So importante yung adrenal. So maliit lang yung adrenal gland, no? Nandyan lang yun sa kidney, malapit. However, problems with the adrenal, particularly adrenal insufficiency, can lead to what is called adrenal crisis, and this can be life-threatening. And when you investigate a patient suffering from adrenal crisis, the patient may have abnormally high potassium levels or hyperkalemia and low sodium levels because of the problems of in terms of aldosterone action. These findings result from the reduced aldosterone secretion and the resultant renal sodium wasting and reduced potassium excretion. So those are some of the clinical correlation that you might get from your discussion of aldosterone. Okay, let's now move on to the other factors affecting sodium reabsorption. Now, your other factors affecting sodium reabsorption, aside from the things that we have discussed earlier, particularly your RAAS system, you have your Starling forces in the proximal tubule. You have your sympathetic drive from the renal nerves. You have your prostaglandins also. So remember, prostaglandins also affects sodium reabsorption. So that's why when you take antiprostaglandins, for instance, meron din effect yan, no? Sa katawan, particularly sodium levels. Also, your atrial natriuretic peptide, or your ENP, is also one of the other factors that affects sodium reabsorption. So let's take a look at these factors individually. So let's start with your Starling forces in the proximal tubule. Your amount of sodium and water that is reabsorbed in the peritubular capillaries, no, from the proximal tubule will depend on the rate and amount of uptake from the lateral intercellular spaces into the capillaries. So therefore, changes in the body fluid volume will change, no, the plasma hydrostatic and oncotic pressure. So for example, increased sodium chloride intake, so increased salt intake, for instance, is mirrored by a rise in your extracellular fluid volume. This in turn will increase your hydrostatic pressure and decreases your oncotic pressure. Kasi pag tumataas yung water content ng isang fluid compartment, bumababa naman yung oncotic pressure because of the increase in water component of that particular fluid compartment. So remember, your oncotic pressure is due to the presence of proteins, no, within your fluid volume compartment. So this is affected. So increase in hydrostatic pressure and decrease oncotic pressure. So sodium chloride and water absorption by the proximal tubule cells will also decrease. So this is your Starling's force and how it affects sodium reabsorption in the proximal tubule. Now let's take a look at your sympathetic drive naman. Sympathetic drive from the renal nerves. No? The baroreceptors in the arteries. So remember, your arteries have baroreceptors. No? They measure pressure within the walls, no, of the blood vessels, no, particularly your arteries. So the arterial baroreceptors will regulate renal sympathetic nerve activity. So for example, a fall in your ECF volume will decrease blood pressure, which is detected, no, by your baroreceptor and will result in an increase in sympathetic activity. So for instance, you have a decreased circulating volume, decreased circulating volume, and this will have decreased BP, no? Kasi syempre mababa yung yung amount of fluid in the blood vessels, so there will be decreased blood pressure. So this is sensed by the baroreceptors in the walls of the arteries, and this will lead to an increase in sympathetic tone. So magkakaroon ng sympathetic nerve stimulation. So a rise in sympathetic nerve activity to the kidney will stimulate the release of renin. Ito na yun, no? Pag nagkaroon ng increased sympathetic tone in the blood vessels of your kidney, then they will release renin either directly or as a result of renal vasoconstriction. And then your catecholamines from your sympathetic nerve will also stimulate sodium reabsorption by the proximal tubule. No? So there will be the, increased tubular reabsorption, sodium reabsorption by the tubules. But however, it is unclear if this increase in sodium reabsorption by the proximal tubule is a direct effect or secondary to altered peritubular forces. And because of the increase in your tubular reabsorption, of course, your circulating volume will increase because also you have increase in water retention. How about prostaglandins? How does it affect your your sodium reabsorption? Your prostaglandins will decrease. Your prostaglandins will affect your sodium reabsorption. For example, when you have a decrease in the effective circulating volume in the body. So if you have a decrease in circulating volume in the body, this will stimulate the production in the cortex of prostaglandin. So prostaglandin will be synthesized, and in the kidney, prostaglandin synthesis happens in the cortex, particularly in the arterioles and the glomeruli. It also is synthesized in the medullary interstitial cells and also in the collecting duct of your epithelial cells. So there are several prostaglandins that are produced. This includes your PGE2, which is produced in your medullary portions of the kidney. You have your PGI2, which is produced in the cortical sections of the kidney. Then you have your PGF2 alpha, your PGD2, and your thromboxane A2. So the main functions of each are different. No? For example, your PGE2 and your PGI2 or prostacyclin are actually vasodilators. So the effect of your prostaglandin actually is to prevent excessive vasoconstriction. So they protect also the kidney tissue from excessive vasoconstriction as a result of the decrease in circulating volume. So also your PGI2 or prostacyclin also stimulate renin release. On the other hand, your PGE2, which is your medullary prostaglandin, promotes water and sodium excretion. So it releases water and sodium within the collecting tubules and overrides the antidiuretic action of your ADH. So therefore, your PGE2 protects the medullary tubule cells from excessive hypoxia when the ECF volume decreases. On the other hand, your thromboxane A2, your TXA2, is a vasoconstriction which is synthesized after repeated kidney damage. For example, this happens when you have ureteral obstruction. So there you have a stone in the ureter. This can lead to damage to the kidney because of the backflow pressure to the kidney. So thromboxane A2, TXA2 is released, and this is a vasoconstrictor. It reduces the amount of blood available for filtration by a poorly functioning kidney. So it prevents the damaged kidney from filtering a large number of fluid. Kasi hindi niya na kaya yung ganung levels of activity. Lastly, your atrial natriuretic peptide, your ANP, is a peptide produced by your cardiac atrial cells in response to an increase in ECF volume. So this is found in the atrial cells and released into the plasma. So your atrial cells, of course, in the atrium, therefore, are involved in sodium reabsorption via your ANP. The action of your atrial natriuretic peptide, or ANP, is to bind. It binds to specific cell surface receptors that leads to an increase in cyclic guanosine monophosphate, or cyclic GMP. So what it does is that it increases your cyclic GMP in the cell surface receptors. And the net effect of your ANP is to inhibit sodium-potassium ATPase and close sodium channels of the collecting duct to reduce sodium reabsorption. So the net effect is to decrease the amount of sodium that is reabsorbed and to decrease the amount of water that is retained in the body. So your atrial natriuretic peptide, ANP, prevents accumulation of so much water in the body. So water and sodium excretion by the kidney is increased by the action of your ANP. Also, your ANP, aside from increasing water and sodium excretion from the body, it also vasodilates the afferent arterioles. So therefore, it increases your GFR. So remember, your glomerular filtration rate is dependent on the amount of blood flow that goes into the kidney. And when you vasodilate the arteriole, especially the afferent arteriole, this will increase your GFR. Also, your ANP inhibits aldosterone secretion. So alam naman natin na maraming action yung aldosterone. So pag pinababa mo yung aldosterone, therefore, hindi na siya magkakaroon ng masyadong ganong kataas na effect sa kidney. It also inhibits your EDH and also inhibits renin release. So importante pala yung atrial natriuretic peptide in terms of controlling sodium reabsorption in the body. So just read in your textbook of further discussion of your ANP, especially in your physiology and biochem. Okay, let us now, in closing, go to the clinical correlation of these basic concepts of fluid regulation in the kidney. So what are the ways by which your kidney responds to certain disorders or diseases in the body that are systemic in nature? So we'll take a look at several of these systemic disorders, including hypertension, congestive heart failure, hypovolemia, and even your hepatorenal syndrome. Okay, let's start with your congestive heart failure. Your congestive heart failure or congestive cardiac failure, so ito na yung term na ginagamit, either CHF or CCF, happens when the heart muscle cannot pump appropriately already the amount of work load that it is expected to do. So the cardiac output falls, so bumababa yung cardiac output, and therefore it fails to perfuse the tissues adequately. So dahil konti na lang yung kanyang naibubugan dugo sa ating blood vessels, hindi na adequate yung perfusion sa mga tissues sa katawan. So your hypoperfusion of the tissues will result in sodium and water retention by the kidneys, leading to edema. So nagkakaroon ng edema because of the problem of the heart. So makikita nyo common sa clinics na pag makita kayo ng mayroong heart problem, edematus din yung patient, lalo-lalo na pag advanced na yung kanilang heart failure. So congestive heart failure is a common end result of all types of severe heart disease. So eventually, pag mayroon kang heart problem, kahit anong heart problem yan, eventually isang endpoint niyan is a failure of the heart. So renal hyperperfusion following a decrease in cardiac output, therefore, is detected by the kidney as hypovolemia. So yung kidney, sabi natin, di ba, nakaka-detect naman siya ng perfusion. May baroreceptors siya, mayroon din siyang sodium receptors. This is detected by the kidney, and this is compensated by retaining sodium chloride in water to increase the circulating volume. No? So as the kidney attempts to increase the circulating fluid volume, peripheral edema develops. Dahil nire-retain ng kidney yung tubig, no, sa katawan ng tao. So this increase in pulmonary venous pressure results in fluid transudation, no? Nagli-leak, no, yung fluid from the capillaries in the lungs and nag-create ng pulmonary edema. So nalulunod yung patient sa kanyang sariling tubig sa baga. So how do we manage patients like this? So nagkakaroon ng dyspnea, difficulty breathing, kasi nagkakaroon ng fluid sa lungs, no, because of this kind of mechanisms by which water salt is retained in the body. How do we manage this? So there are several ways by which congestive heart failure is managed. No? And this includes reducing the fluid load within the body and therefore decreasing the workload of the heart. So yung ultimate aim natin is mapababa yung volume of water in the body. And this is done by the use of diuretics, using ACE inhibitors, using nitrates, and using vasodilators like hydralazine. So diuretics are used to produce symptomatic relief from pulmonary edema kasi nga diuretics, they increase elimination of water from the body, so nare-relieve na yung pulmonary edema. On the other hand, your ACE inhibitors act as vasodilators also by reducing the synthesis of angiotensin II, and also as diuretics by decreasing aldosterone synthesis. So multiple action ang ginagawa ng ACE inhibitors natin. Yung nitrates naman, they result to venodilation. So nagbabasodilate yung veins, and this decreases no preload. So yung pumapasok na load, no, from the venous system to the heart, no, to the right side of the heart, decreases, and the preload of the heart decreases. So nare-relieve ngayon yung trabaho ng puso natin. Also, vasodilators are used to reduce afterload. So ito naman yung mga arterial system, dinidecrease yung pressure, yung resistance, no, para hindi masyadong mataas yung pressure where the heart is acting against, no, kasi alam naman natin yung afterload, that is the pressure in which the heart is pumping against, no. And if you decrease this pressure, decrease the afterload, this also relieves the workload of the heart. So these are ways by which heart failure is managed, no, in the clinics. On the other hand, the prognosis of people who suffer from CHF or CCF depends on the overall clinical picture and the extent of the cardiovascular disease. No? So just as a reminder, your congestive heart failure can be caused by several problems. One is it could be a pump failure, low output heart failure, so walang masyadong mahina yung heart in terms of producing the necessary output. It can also be due to high demand, no? Increased demand, o tawag natin dyan, high output failure. A normal heart can still also develop heart failure if the loads in which it is working is very high. So you have a high afterload. For example, meron kang hypertension, di ba? Ibig sabihin yan, mataas yung pressure sa katawan, so yun ang problema ng heart. Masyado siyang nagtatrabaho kasi the pressure against which it is working is so high. So yan ang problema sa hypertensive patients. Then it can lead to high output failure. However, an abnormal heart, so for example, meron ka ng patient na mayroong heart problem, like meron siyang heart attack before. So mahina na yung kanyang puso. Kahit normal naman yung load, wala siyang hypertension, So dahil mahina yung kanyang puso, hindi niya kaya yung pressure against which it's working, it can still develop a failure due to even though normal yung pressure ng blood vessels. So the kidney tries to increase fluid volume, leading to peripheral edema and eventually leads to pulmonary edema. So when you are looking at patients with congestive heart failure, always look at your lungs, no? Kasi doon mo makikita yung endpoint, no, ng congestive heart failure. Now let's take a look at hypovolemia and shock. Shock is a medical emergency in which the vital organs are inadequately perfused. So hindi nagkakaroon ng enough blood perfusion yung mga vital organs. So as the amount of oxygen and nutrients delivered to the cells is inadequate to meet the demands of the body, the resulting hypoxic state within the cells leads to anaerobic metabolism, and there is inefficient clearance of these metabolites which builds up in the cell. So as a result, nagkakaroon ng toxicity, because of the buildup of these metabolites. So hypovolemia and mild shock causes tiredness, dizziness, and feeling of thirst. However, pag severe yung hypovolemia, this will result in a decrease in circulating volume, which will stimulate sympathetic activity to maintain blood pressure. As a result, nagkakaroon ka ng tachycardia, peripheral vasoconstriction, nanlalamig yung peripheries, and you will have increase in myocardial contractility. The heart is trying to compensate by pumping faster and harder. So vasodilation occurs in the vital organs, for example, the heart, the lungs, the brain, to maintain blood vessels. But this is at the expense of the other parts of the body, that are sacrificed as a result, because they wanted to maintain enough blood pressure in the heart, the lungs, and the brain. If there's inadequate compensation, nagkakaroon ng tissue hypoxia, and eventually failure of the organs, nagkakaroon ng necrosis in the vulnerable organs. For example, yung kidney, nagkakaroon ng acute tubular necrosis in settings of hypovolemia and shock, and that can lead to problems. Another condition is your cardiogenic shock. So this happens when the heart fails to maintain cardiac output. For example, when there is ischemic heart disease or arrhythmias. As a result, there is a decrease in tissue perfusion, and this happens in a very fast manner, dramatic manner, and your venous pressure increases, causing pulmonary or peripheral edema. Usually in cardiogenic shock, the prognosis is poor, and patients generally die in 90% of the cases. There's also massive pulmonary embolism, and pericardial tamponade can also cause the shock. On the other hand, your vasodilated shock happens when you have sepsis, anaphylaxis, and spinal trauma, which decreases total systemic resistance and therefore can also reduce the blood pressure sufficiently to cause shock. On the other hand, your hypovolemic shock is a result of active reduction in effective circulating volume, for example, due to hemorrhage from blood loss or loss of plasma from burns. Itong mga born patient, they can go into hypovolemia, not because they're losing blood per se, but they're losing plasma. So they can go into hypovolemic shock. Also, loss of water and electrolytes due to diarrhea and vomiting, and it can also lead to hypovolemic shock. Patients can die from diarrhea and vomiting. So all of this will lead to a fall in circulating fluid volume, and to counteract excessive vasoconstriction, a result of the sympathetic activity in the kidneys, more vasodilating prostaglandins are secreted within the kidneys to maintain adequate blood flow through the kidney in order to allow sufficient glomerular filtration unless the shock is severe. So the loss of large amount of fluid has two major consequences. Unang-una, pag nagkakaroon ka ng fluid loss, you have volume depletion. And secondly, you have electrolyte and acid-base disturbances. So how do you treat hypovolemia? So hypovolemia needs to be treated by fluid replacement to restore extracellular volume. If blood flow to the kidney is not restored, acute kidney injury results from tissue hypoxia and tissue necrosis. Now, let's now go to your hepatorenal syndrome. Your hepatorenal syndrome is a condition in which patients with liver disease have reduced urine flow or oliguria. And this is especially in patients with portal hypertension and ascites. So your portal hypertension results from an increase in resistance to blood flow from the gut and spleen that results in venous congestion, possibly due to the release of nitric oxide. And there is peripheral vasodilation. So the resulting decrease in blood pressure will cause sympathetic activation, an activation of your renin, angiotensin, aldosterone system, leading to intense renal vasoconstriction, which leads to oliguria and renal failure. So the circulating blood volume can also be reduced in liver disease due to the formation of ascites and edema. This results from portal hypertension and impaired synthesis of albumin. Dahil pag meron kang liver problem, syempre yung liver is the site for the synthesis of albumin, and albumin is one of the major protein that creates oncotic pressure. No? So decreasing the oncotic pressure, oncorodesmotic pressure in the capillaries will now favor fluid movements out of the blood vessels. So this shifts fluid out of the vasculature and therefore contributes to acute kidney injury. So ito yung nangyayari sa mga pasyente na mayroong mga liver problems or portal hypertension. Lastly, let's take a look at hypertension. Hypertension, this is very common in many situations. And we know that your blood pressure is influenced by the interaction of genetic and environmental factors, no, which regulate cardiac output and total peripheral resistance. So remember, the formula for blood pressure is cardiac output times total peripheral resistance. So your blood pressure is a product of your cardiac output and your total peripheral resistance. Now, your kidney influences blood pressure by regulating the ACF. And they also release what we call your vasoactive substances. Ito yung mga vasoconstrictors like angiotensin 2 and your vasodilators, your prostaglandins, for instance. So your renal autoregulation maintains renal function despite variations in systolic blood pressure. So any changes in the ECF will affect your blood pressure. And therefore, the kidney compensates for these changes by controlling sodium and water excretion, as we have discussed earlier. So if these mechanisms are disturbed, there will be uncontrolled sodium and water retention, resulting in hypertension. So hypertension, as defined by the World Health Organization, is a sustained blood pressure of 140 over 90 millimeter mercury or above. However, we have what is called your essential hypertension, and this accounts for about 95% of all cases of hypertension that you see in the clinics. So the most common form of hypertension is essential hypertension, and the cause is generally unknown. Initially, there is an increase in cardiac output as a result of your sympathetic overactivity. However, in the latter stages, the increase in blood pressure is maintained by an increase in the total peripheral resistance, but your cardiac output is now normal. So hypertensive changes that are usually seen in the kidney will include, in your pathology, you will discuss this, you have your arteriosclerosis of the major renal arteries and your hyalinization of the small vessels with intimal thickening. So these are some of the pathologic changes that you see in your blood vessels as a result of hypertensive changes in the kidney. So this can lead to chronic renal damage. You call this what you call this as your hypertensive nephrosclerosis. And generally, you will see a decrease in the size of your kidney. So malignant or accelerated hypertension is a rare and rapidly progressing form of severe hypertension. And I've seen one in the clinics where a patient comes in with, a young patient typically comes in with blood pressure over 200, over 200 systolic BP, and then you cannot decrease it no matter what you do. And it's typically progresses and eventually leads to acute renal failure or heart failure. And sometimes even before the kidney fails, the brain blood vessels also fails, nagkakaroon ng stroke minsan. And I have patients like this, no, very young, with malignant or accelerated hypertension, and eventually leads to coma. Now, secondary hypertension, on the other hand, are caused probably by renal causes. 80% of your secondary hypertension are renal in origin. Well, the rest can come from endocrine problems or even drugs, and occasionally from your coarctation of the aorta. So renal causes of hypertension will include impaired sodium and water excretion, increasing blood volume, and your stimulation of your renin release. You also have diseases of the kidney that results in hypertension. For example, diabetes. So diabetic nephropathy, any cause of glomerulonephritis or chronic pyelonephritis. So pag meron kang infection of the kidney, this can lead to chronic pyelonephritis, or even your polycystic kidney disease, no, can also lead to hypertension. You also have your renal artery stenosis that can reduce perfusion in the kidney, and therefore will lead to excessive activation of your renin angiotensin system, leading to hypertension. So for your clinical correlation, remember that your kidneys are influenced or influence blood pressure by regulating ECF volume, and also by releasing vasoactive substances, including your angiotensin II and your prostaglandins. On the other hand, some of the causes of secondary hypertension can be due to endocrine problems, including your Cushing syndrome, your pheochromocytoma, which is very rare. You will also have estrogen levels due to the use of contraceptive pills, and even pregnancy can lead to hypertension. That's why you have your pregnancy-induced hypertension also, which is a problem in the clinics. You also have your primary hyperaldosteronism, called your Conn's syndrome. So in primary hyperaldosteronism, for instance, there is chronic excessive secretion of aldosterone. So pag masyadong mataas yung secretion ng aldosterone because of adrenal cortical adenoma or hyperplasia, the patient will present with hypertension and hypokalemia. So the diagnosis of your primary hyperaldosteronism is diagnosed based on the triad of hypokalemia. So you have decreased potassium levels, hyperaldosteronemia or increased aldosterone, and decreased renin. So treatment of your primary hyperaldosteronism is by surgical removal of the adenoma, and the cure rate is about 60% for aldosterone antagonist using spironolactone. So studies have shown that hyperaldosteronism may be a more common cause of hypertension than previously realized. So many patients that we might be actually seeing in the clinics might have problems with adenoma in your adrenal glands. Drugs that cause hypertension might include corticosteroids, your combined oral contraceptive pills, even NSAIDs. No? NSAIDs can cause hypertension, and even cyclosporine, they can cause hypertension. Finally, your coarctation of the aorta is a congenital narrowing of the aorta, and this reduces renal perfusion and stimulates renin angiotensin aldosterone system. So how do you manage hypertension? You have several ways to manage. Of course, lifestyle changes is the foundation for hypertension management. It is done by weight reduction, reduced alcohol intake, salt restriction, regular exercise, and smoking cessation. But your treatment for hypertension include drugs like diuretics, ACE inhibitors, calcium channel blockers, and beta blockers. So your ACE inhibitors block the formation of your angiotensin 2, and it is a potent vasoconstrictor. So therefore, when you block it, it promotes vasodilation. No? So ACE inhibitors like your captopril, ramipril lower blood pressure by reducing total peripheral resistance and by inhibiting the local tissue and renin-angiotensin system. So ACE inhibitors also reduce proteinuria and delay the progress of renal disease in patients with diabetic nephropathy and patients with proteinuric non-diabetic renal disease. They are also able to treat congestive heart failure. So ACE inhibitors also used to treat patients with heart failure. The side effects of ACE inhibitors will include persistent dry cough and allergic reactions or rashes. On the other hand, diuretics are used to increase the volume of urine produced by increasing renal sodium excretion or natriuresis, which is followed possibly by water. So each type of diuretic has specific actions on the neurophysiology of a particular segment. So they can either act on the membrane, transport proteins found in the luminal surface, or they can interfere with hormone receptors, or they can inhibit enzyme activity. So osmotic diuretics can be induced by an inert substance that is not reabsorbed in the tubule, and the proximal tubule and the descending limb of the loop of Henle allow the free movement of water molecules with the use of your osmotic diuretic. On the other hand, the most powerful diuretic are your loop diuretics. They can cause up to 20% of filtered sodium to be excreted. So they inhibit sodium transport out of the thick ascending limb of the loop of Henle into the medullary interstitium. So examples of your loop diuretics include furosemide and bumetanide. So the loop diuretics act by inhibiting the sodium-potassium 2-chloride co-transporter on the luminal membrane of the cells, and this inhibits sodium reabsorption. Therefore, they dilute osmotic gradient in the medulla and increases sodium and water excretion. So loop diuretics are used for acute pulmonary and peripheral edema, to reduce end-diastolic ventricular filling pressure, pulmonary congestion, acute hypercalcemia, hypertension, nephrotic syndrome, and your acute kidney injury. So take note that it has side effects that include hypokalemia, hypokalemic metabolic alkalosis, hypovolemia and hypotension, hyperuricemia, hypomagnesemia, ototoxicity, and allergic reactions. So they should be used with caution. Your thiazide diuretics, on the other hand, reduce active sodium reabsorption in the early distal tubule by inhibiting the sodium chloride co-transporter. As there is more reabsorption of sodium in the loop of Henle, the loop diuretics are more potent than thiazide diuretics, and thiazide help reduce peripheral vascular resistance and consequently are used to manage hypertension. They are also used in congestive heart failure and also in nephrogenic diabetes insipidus. You can also use your potassium-sparing diuretics. The potassium-sparing diuretics act in the collecting ducts. For example, your spironolactone. They can inhibit the optical sodium in the cells at the distal nephron. For example, amiloride and triampheline. Aldosterone is also a mineralocorticoid that increases the activity of the sodium-potassium ATPase pump, your potassium and sodium channel, and resulting in sodium absorption and potassium secretion. So your spironolactone competes with aldosterone for the receptor site. So this reduces sodium reabsorption in the distal nephron and decreases potassium secretion. That is why they have potassium sparing activity. You also have other drugs, like for example, your carbonic anhydrase inhibitors, because your carbonic anhydrase is found in many places in the nephron, but primarily in the brush border of the luminal membrane of your proximal tubule cells. So your carbonic anhydrase inhibitors interfere with the action of your carbonic anhydrase and inhibits bicarbonate reabsorption, and the presence of bicarbonate in the lumen will reduce sodium reabsorption, which continues into the distal nephron, which enhances potassium secretion. Your beta blockers can also be used, but they are no longer the frontline drugs for the treatment of your hypertension. So renal artery stenosis, in closing, is a condition where between 2 to 5% of your hypertensive patients have hypertension secondary to narrowing of one or both of your renal arteries, which is called your renal artery stenosis. This reduces the pressure in the afferent arterioles, which stimulates the GJ apparatus to secrete renin. So therefore, the affected ischemic kidney will be small. So there are two types. You have your atherosclerotic renovascular disease, and you have your fibromuscular dysplasia. So we should take note that renal artery stenosis may present with hypertension, suddenly decreasing renal function with ACE inhibitors, a renal bruit or renal recurrent flash pulmonary edema from fluid retention. So how do you treat renal artery stenosis? You use drugs to control the blood pressure and vascular risk factors. You also use angioplasty to dilate the stenotic region for this. But these are patient needs careful clinical management. So that sums up our discussion on fluid volume regulation in the kidney. I hope you're able to get the major concepts for that.